I'm Rebecca. I'm trying to learn osteology. Today, spongy bone tissue. And after we've done that, we're going to do wrist training. If you participate in the wrist training, then it's relatively honest. We left the beginning, but let's repeat it again. In contrast to compact bone tissue, spongy bone tissue does not contain true osteons. True osteons. I never paid attention to the true. So reading it out is a good idea. So, because what we described then was very similar to the osteons, which we're going to do it later. Probably it is a central channel with a concentric element around them. Then inside of the spaces between them there is the lacuna. Inside of them the cannululi coming out from the osteocytes, which are producing and maintaining the blood thing. So it's a whole setup of a whole city structure. The spongy bone tissue, not true one, but very similar. They are called ventriculae. They are also these. Now let's see. It consists of lamellae, which are arranged in an irregular lattice of thin columns of bone called tuberculae. The microscopic spaces between the tuberculae of some bones are filled with red bone marrow, which produces blood cells. Within each tuberculae are osteocytes that lie in lacunae. So they have also osteocytes lying there in lacunae, as the osteons have also osteocytes lying in lacunae. That's a bit differently, but similar. Maybe it's differently with there's no channel. The osteocytes are along the diaphyses of the whole bones along the long side. The spongy bone is in the head. So here on the long side of the diaphyses, there is the osteons, and the head is the spongy bone tissue. So there are no central long-going blood vessels in the Volkmann channel perforating the bone, also not because they're just directing it. So it's differently, but it's also osteocytes there lying in a good structure and producing lots of things. Within each tuberculae are osteocytes that lie in lacunae. Radiating from the lacuna are canaliculi, as with the osteons. Osteocytes in the tuberculae receive nourishment directly from the blood circulation through the medullary cavity. They get blood not through the Volkmann channels, through the whatever it's called, the peridium, periosteum, and the compact bone through nutrient artery and nutrient forearm, so it goes not through it. They get it directly from the medullary cavity in the inside of the diaphyses of bone. Spongy bone tissue makes up most of the bone tissue of short, flat, and irregular shaped bones. Most of the epiphyses of long ones, so the epiphyses, the head and the bottom is called epiphyses of bones. So in flat, irregular shaped, short bones, and in the epiphyses of long bones, there's the spongy bone tissue. And because it's lying in a different place, it has a different infrastructure where the blood comes to it, and that seems to be the main difference between the tuberculae and the osteons, or the osteons and the true osteons, whatever. We're going to do it later in detail. You want to read the rest, and we don't have so much time. At first glance, the structure of the osteons of compact bone tissue may appear to be highly organized, whereas the tuberculae of spongy bone tissue may appear to be far less well organized. However, the tuberculae and spongy bone tissues are precisely orientated along lines of stress. A characteristic that helps bones resist stress and transfer force without breaking. Spongy bone tissue tends to be located where bones are not heavily stressed or where stresses are applied from many directions. So they are also the tuberculae. They are also organized and along the lines of stress. The tuberculae and spongy bone tissue are precisely orientated along lines of stress, as the osteons also in the other part. And they can also be forming more where more stress is applied onto them. And they are more in the regions where there's less heavy stress applied on them, on the spongy bone tissue. Spongy bone tissue is different from compact bone tissue in two respects. First, spongy bone tissue is light, which reduces the overall weight of the bone so that it moves more readily than pulled by skeletal muscles. Second, the tuberculae of spongy bone tissue support and protect the red bone marrow. The spongy bone tissue in the hip bones, ribs, breast bones, back bones, and the ends of long bones in the one side of the red bone marrow is the only side of red bone marrow, and thus hematopoiesis in adults. So, the spongy bone tissue in the hip bones, ribs, breastbone, back bones, and the ends of long bones is the only side of red bone marrow, and thus of hematopoiesis in adults. The tuberculae are protecting the spongy bone tissue in the center, which is making the hematopoiesis with red and white blood cells. Bone scan. A bone scan is a diagnostic procedure that takes advantage of the fact that bone is a living tissue, so it lives. A small amount of a radioactive tracer compound that is readily absorbed by bone is injected intravenously. The degree of uptake of a tracer is related to the amount of blood flow to the bone. A scanning device measures the radiation emitted from the bones, and the information is translated into a photograph or diagram that can be read like an X-ray. Normal bone tissue is identified by a consistent gray. Okay, the person gets injected intravenous some type of compound, a tracer compound, some stuff, and the bones are sucking that stuff in. They're drinking it and building it in them. And where the bones are drinking the strongest, they are the most healthiest drinking. I think that is the most healthiest part. They are getting the most of it in them, and they are then decolorating on the X-ray or something. But it is at least not very dangerous. Maybe not at all dangerous. As you said, again, this is no, I didn't say it here. This is no medical advice. I'm just reading and trying to understand it. So a person takes something, the bones are drinking it, building it in them, and they are then on an X-ray visible that someone has taken it. And now we know what part of a bone is better. It's better connected to the infrastructure of the blood vessels or whatever. A scanning device measures the radiation emitted from the bones, and the information is translated into a photograph or diagram that can be read like an X-ray. Normal bone tissue is identified by a consistent gray color throughout because of its uniform uptake of the radioactive trace. Okay, normal bone is taking everywhere the same up, everywhere a little gray. Darker or lighter areas, however, may indicate bone abnormalities. Darker areas are called hotspots. Areas of increased metabolism that absorb more of the radioactive tracer. Hotspots may indicate bone cancer, abnormal healing of fractures, or abnormal bone growth. Lighter areas are called count spots. Areas of decreased metabolism that absorb less of the radioactive tracer. Count spots may indicate problems such as degenerative bone disease, decalcified bone, fractures, bone infections. It is interesting. So cancer is listed only by the hotspots, only if you're taking more, not by the lesser ones. Count spots may indicate problems such as degenerative bone disease, decalcified bone, fractures, bone infections, Paget's disease, and rheumatoid arthritis. The bone scan not only detects abnormalities 3 to 6 months sooner than standard X-ray procedures, it exposes the patient to less radiation. Okay. I don't know how we take now the photograph, but by an I don't know. Who's now by the X-ray making the little dangerous thing? Is it the thing which is swallowed? Or is it the X-rays themselves? Or is it both? Or just one of them? Whatever. It is earlier visible that there is some part of the bone, the tracer or the thing injected is more built in, or it's another place less built in, half a year earlier through such a bone scan as it is for an X-ray, and it even makes less damage. Okay, we're actually over time, but let's take one look at one minute to look at it. Histology of compact and spongy bone. A. Section through the diaphysis of a long bone from the surrounding periosteum on the left. Section through the diaphysis of a long bone. So where's A? Where's A? Where is A? And B is where? A is there. B is there. A and B. Okay. A section through the diaphysis of a long bone from the surrounding periosteum on the left to compact bones in the middle. Okay. The spongy bone and the medullary cavity on the right. So that is the bone, that is the outside, the periosteum, that is the compact bone, and there's the inside, here's the medullary cavity, and here it starts again with the compact bone, and then also the bone is actually that big. It's just half a cake. The inside of the upper left shows an osteocyte in the lacuna, so that's the osteocytes, the canal lacuna, and the whole thing is the lacuna. No, that is the lacuna. What is the yellow thing? The lamellae? Whatever. A photomicrograph of compact bone tissue is provided in table 4.3 on page 126. Okay, a bunch of things, we don't have time for them, and a bunch of other things. There are the space for the bone marrow is in the middle. There are the osteocytes, there's the osteoclast, interstitial lamellae. Okay, we're going to make that later in detail. Page 126. Cartilage, bone tissue, blood tissue. Bone tissue of the femur, so the leg bone, what do you call it? Down left. lamellae, lacunae, sectional view of an osteon or Haversian system of femur fiber. So the central Haversian canal is in the center, the lamellae. How big is it? LM285. This must be how big it is. So 285. The lamellae, the lacunae, central Haversian line, canaliculi, go to the sides, okay. Okay, more or less. We're gonna look later. That was the osteology part. If you were here for osteology, you can go directly to the next part of osteology. And then we will continue with osteology. If you stay here and participate in the wrist training, then it's with your own risk. Good and stable stance, arms up with fists and bring them down and up the spotlight. Now the fists and in and out. And there's the flashlight. We are having 3 rules. Flat hands and in and out of the position. The first rule is that it's stopping immediately as soon as there's pain. Flat hands and open and close the pancake flip. And hands out and down and up the T-Rex in the morning. The second rule is that we're going only as far as we can go with a little bit of it. And now the fists, the quadrangular castle architect, in, up, press evenly with all 5 fingers, out, down. And the third rule is that we're going out. No, the third rule is that we stop it immediately. No, that's the first. The third rule is that we just want to strengthen, not exhaust. If you want to take a break, do it whenever you want. Hand up and down and press from the inside. The crab anxious to have fever. And pull from the outside. And the top. And the outside. Our hand down into flexion and press from the inside. And both arms up with strong fists, down into flexion, and down the arms, and up again. And around, and down again. Up, one more time, around, down. And now the field daisies nu Cynthia's director. Fist, open and flare, down. Open and flare, down. And now the T-Rex in the gym. You can press onto a tennis ball or you just make a strong fist and release. And press. Release, switch, and press. Release, and again press. And now a cautious big bang. Press with the fingertips of one hand on top of the fingertips of the other hand. Fingernails open and close. And on the other side. And now the bicycle bridge. Flat hands, bend the middle knuckles. Up again. Flat hands and bend the middle knuckles. Up again. And the arms up, strong fists into flexion, out, extension with flat fingers. In strong fists, flexion, out, extension, flat fingers. In strong fists, flexion. And now the claw, flat hands and make claws, flare the fingers apart. Out again. Claws, flare apart. Out. Flare apart. And now you can take a break. Now the frog testing the water temperature. Flat hands and down with flat fingers. Up, strong wrist flexion. Again down. And up. And down. And now the ice axe. Flat hand, bend it at the knuckles and press onto all 4 fingers. Up again. Up. Bend it at the knuckles, press into all 4 fingers. Up. One arm out. Try to flex the bicep. Flare the fingers and pull them in. Okay. And again. Other arm out. Flex the biceps if possible. Flare the fingers. Press against them a bit. Okay. And now the sundial. Have a soccer stopping out with a long arm at the side. Let it fall down. Try to catch it again. And on the other side. And now long arms, strong fists, and the fists into flexion. Out extension, flat fingers. In strong fist flexion. out extension 1 by 1. And now go with moderate force of the middle part of the lower arm. And the other side. And with posterior training. I thank you very much, and until next time.